So, we'll continue the study of the lung diseases cases from where we stopped last time. We had the case of an idiopathic diffuse fibrosis, I think, which changed the lung to the honeycomb pattern. And we'll try to understand the main differences between restrictive lung disease and obstructive lung disease. In restrictive lung disease, fibrosis is prominent, perhaps idiopathic or due to a specific cause, as we'll see today. From the functional exams of the lung function, which is the hallmark to show us that one lung disease is of the obstructive type and another lung disease is of the restrictive type, which is the main marker from lung function tests. Do you remember? Yes.
It's the ratio between...
Excellent. It's the ratio between FEV1 to FVC. So, this ratio, when is it decreased? In which type of lung disease? Yes, in obstructive. On the contrary, in restrictive lung disease, such as those we'll study today, it is increased. Okay? So, today we'll continue our study of restrictive lung diseases of known etiology. That means we know the factor that causes fibrosis. And here is the first case where we have these peculiar, this strangely shaped fibers. And it's from a man who has interstitial fibrosis by chest radiograph and calcified pleural plaques. These plaques, which develop in the pleural, if they are too big, they may affect the lung parenchyma function. So, these are images taken from the cytological smears of his sputum. So, what are these objects? And you see, one of them appearing somehow blue, that means we have a specific stain demonstrating ferritin. This is a ferritinous coverage of the fiber, and it is highlighted by stains, iron stains, such as pearls. It's the most commonly used stain, histochemical stain, for iron. So you see that this fiber has an iron coverage, and these are asbestos fibers. This is the stain, the iron stain that highlights, because these ferruginous bodies have been formed by the action of macrophages. So, it's one form of restrictive interstitial disease, and it has to do with the proportion, the amount of exposure, and there is a risk for cancer development, as you will study. Now, here are the fibers again. You see this one looks like shish kebab, and this is another fiber, and which is the predominant cell that is responsible for all these fibrogenic cytokines secretion. Because this is a foreign body that has entered the microenvironment of the lung. That means there must be some inflammatory cells which are motivated to destroy this foreign body. However, they do not succeed, and that's why their persistence on the local microenvironment induces fibrosis. So, which cell is predominant in this procedure? Yes, the macrophage, right? And some, remember from our lessons on inflammation, some very crucial fibrogenic factors that, yes, that's right. These factors are fibrogenic cytokines, and most important, I think, is transforming growth factor beta, all right? That induces the formation of tissue, fibrous tissue. This is similar to idiopathic disease. However, in idiopathic disease, the fibrous areas are dispersed in various sites of the lung parenchyma, whereas in asbestosis, we have the pleural involvement, not the lung parenchyma itself. And in silicosis, that we'll see next, nodules are formed within the lung parenchyma. In any case, what will be the treatment for a severe interstitial fibrosis or fibrotic disease? We'll try to block the fibrogenous factors, and then up from one point and on, transplantation is the only therapy. Yes?
What condition must be made for this to be formed inside the body? Do we need to inhale something easy?
Yes, it's mainly, now in these cases that we know the causative factor, it's something that you are exposed mainly through your profession.
Okay.
Yes, it's some sort of environmental disease having to do with the environment in which you work. It's mainly workers, and it has some specific professionals which are mainly affected by exposure to asbestos. That's why all doctors having to do with the hygiene of professional environment should give the correct instructions so that this exposure is the minimal possible. So this was asbestosis. And here we have a problem. You see, the problem here is located in the pleural. And we have these nodular densities, you see here. And these are not mere plaques. This is a tumor having to do with the lining of the surface, of one layer of the pleural surface. One layer is in connection with the lung parenchyma, the other is in connection with the chest wall. These layers, if they are in the pleural, similar layers are in the pericardium, and similar layers, double, are in the peritoneum. What cells form their lining? What cells form their lining? Because these are the cells which can become neoplastic. So such layers are throughout the cavities of the body are lined by mesothelial cells. So the tumor would be a mesothelioma. It's potentially malignant, a malignant tumor mainly. However, if we deal with the lung, the most common malignant neoplasms in the lung may be metastatic. So we have a problem here, because the mesothelioma can have an epithelioid or a sarcomatoid phenotype. So if it has an epithelioid phenotype, the cells will look epithelial. So we have to make a differential diagnosis between the mesothelioma and an adenocarcinoma, either primary adenocarcinoma of the lung or a metastatic adenocarcinoma to the lung. So we have to look for some markers which are specific for identifying the mesothelial origin of the tumor. Because this is not an epithelial tumor, although it may look like morphologically if we have the epithelioid subtype of mesothelioma. And such markers are calretinin, markers of mesothelial origin of cells. So this is a mesothelioma developing here. And if it continues to grow, you understand that it will cause problem to the function of the lung. So, now, here is another area of fibrosis in the lung. And this patient, you see he worked in tunnels, and he has increasing dyspnea for 10 years. This is the microscopic appearance, and we can find something, we can have a very important finding if we study the tissue under polarized light. So this is a crystalline material, like a needle-shaped, and these are crystals of silicosis. And this pattern of interstitial lung disease forms nodules, quite round accumulations of fibrous tissue in which these crystals can be detected. Of course, the crucial cell is again macrophage, and here are the factors, the cytokines that are secreted by the macrophage, and fibrosis is the end result. And it can be quite massive when progressive, and the cause will be restrictive lung disease. Now, let's have a look here. Here is a CT scan. We have this sort of reticulonodular pattern. Yes, this is another pattern of, it can be fibrosis. However, when we have a nodular component in the interstitial infiltrates, we might think of something else as well. And this is granulomatous disease. Do you remember the types of granulomas? The types of granulomas that we have discussed in our previous lesson? There are two types. One is foreign body granuloma, where you have giant cells, that means accumulated macrophage forming multinuclear giant cells. And the others are immune granulomas, which are composed by a specific type of mononuclear cell. It's no longer a macrophage because it does not phagocytose any longer. And these are epithelioid histiocytes. They form immune granulomas. That means after representation regulated by the immune system. So it can be granulomatous disease, and these are the activated epithelioid macrophages which have been activated by CD4 positive helper T lymphocytes through interferon gamma mainly secretion. Yes. Which the immune and the foreign body granuloma, where they phagocytose foreign bodies, a foreign tissue, a foreign particle. Now, here is a case of a lymph node. Let's have a look at the patient's history. It's a 39-year-old woman with worsening dyspnea and visual impairment. That means it is a polysystemic disease. Something has affected her vision, fatigue, and weight loss. And we have an elevation of gamma globulins, which are gamma globulins are all the immunoglobulins, all right? And this could be related to either an infectious cause or another cause that we are going to see now. So we have an enlarged hilar lymph node, and a biopsy is taken, not a biopsy through a needle. It can be, the lymph nodes can be examined in this way through fine needle aspiration. However, in this case, the node was excised surgically. And the location of the enlarged node is quite typical because it has to be central in the lung. close to where the main bronchi come out, right? Centrally, we have these nodes. And what do we see here? Can you discriminate the normal lymphocytes that make the node from the pathologic structures? Who can show me? Where is the normal lymphocytes? Where are they? What do you think? Because in this image, we have an abnormal finding, and we have the normal lymph node structure. Yes, tell me. Yes, so which is the, we have the marker here, oh, the pointer. Where is the pointer? No pointer, that's okay. Show me in the screen, on the screen. Yes. Is this normal? What do you think? How could you describe this cell here? Look what it has in it. What is the lymph node composed of? Which cells make the lymph node? The lymph node is not an epithelial structure. It belongs to hematopoietic cystic system. So what is the lymph node consists of? What cells make the lymph node that you have studied in histology? You saw the B zone of the lymph node, the T zone of the lymph node. Which cells do you expect to see in a lymph node? What tissue is there? So show me where are the lymphocytes in this image. There they are, on the right. So these are normal. And we have some foreign structures, abnormal structures. And what is their configuration? They are round structures with round borders. This is the abnormal finding. And they took the lymph node because what did they want to exclude? They wanted to exclude the possibility that this is a metastatic lymph node from cancer. That's why they took the material. In this case, they removed the whole node, lymph node, but they could have a fine needle aspiration. So we found some round structures which are composed of which type of cells? I can see two cells, at least two cell types here. One is these giant cells. Have a look. Multinuclear giant cells. Is this a specific type of giant cell, multinuclear giant cell? Is it a foreign body type giant cell or another type? You see that all nuclei are one next to the other. So which giant cell is this? Langhans. So we see giant cells of Langhans type. And what should we look for now? That we see granulomas with Langhans type giant cells. And what are all the other paint-colored cells which we could not see when one cell ends and the other cell is? That means their borders are indistinct. We cannot define one cell from the other. Which is this type of cell? Pale staining cells? We've said that before. Which type is this? Forming the granuloma. They are histiocytes. Epithelioid, because some time ago they looked like epithelial cells. They have nothing to do. They have nothing to do with epithelial cells. They were macrophages, but now the immune system has transformed them to epithelioid histiocytes. So what type of granuloma is this? Immune granuloma. Since we have an immune granuloma in a lymph node, even though there is no caseous necrosis in it, they are non-necrotizing granulomas. However, which disease we must rule out? Tuberculosis. So we have an acid-fat stain, Gill-Nielsen stain, histochemical stain, and it's negative. So this is not This is not tuberculosis. Is there another chronic granulomatous disease characterized by such structures? It's sarcoidosis, which is a diagnosis of exclusion. That means you exclude foreign body cell granulomas. You exclude tuberculosis, all right? And then you think of sarcoidosis. And this is quite a space-occupying disease because remember, the type we had all those reticulonodular infiltrates within the lung parenchyma. It mainly affected the central part of the lungs. However, it could spread throughout the lung parenchyma, and when time passes and we have all these epithelioid macrophages, which tissue will be formed in this area? Fibrous tissue. So, on the end stage of sarcoidosis, we may have a restrictive lung disease as well. If it goes on and on, fibrosis will develop.
How do you stop this?
Therapy. I'm not so sure. We'll see internal medicine, a textbook, and tell you. I'm not so sure what you give in sarcoidosis. Probably something having to do with the growth factors secreted by these cells. That's probably. Now, let's have a look here at this chest CT scan. What can this be within this vessel here? It is a very big vessel. Let's look at the patient's history. So we have a 20-year-old woman with a 6-year history of intermittent pleuritic chest pain. And she's a very young woman, and dyspnea. Examinations reveals tachycardia, a right ventricular gallop, and her chest is like this. So, what can form within this vessel? What do you think this is? Which is here highlighted by the CT scan. What can this be? This is a very large vessel, and what vessel can it be here? The pulmonary artery. And what has it in it? What can we expect to see in the lumen of a vessel, and not blood, of course? What can that be? Yes? The? If we have an atheromatous plaque, the wall of the vessel will mainly affect it. When, of course, we have a change, an abrupt change in the blood, what will we have in the lumen? A thrombus. So, in case that we have only a thrombus, not an atheroma, just a thrombus, what do we think of? What has happened? This embolism. This is pulmonary embolism. And what's the strange here, the strange thing from a history is the young age of the patient. So how can this be justified? This is pulmonary embolism, and she had a history of smaller embolisms, yes, and when we have all these, the pulmonary embolism in a young patient, a young age, something is wrong with the blood coagulation. You see, it's something heritable. In middle-aged to older patients, what would be the main cause of embolism? What would you think? Which patients are prone to develop pulmonary embolisms? Yes? In the course of infections. Yes. One, yes. Other patients, the blood of whom makes thrombi?
Patients with cancer.
Patients with cancer. And there is a syndrome named Trousseau syndrome that we have migratory thrombophlebitis, and it's most commonly, not always, most commonly related to pancreatic cancer. But in any case, cancer patients must take heparin injections because they may die of pulmonary embolism. And of course, we may have a complication of systemic lupus erythematosus, the antiphospholipid syndrome. And this is a case where we have many clots. Now, here is the autopsy specimen from a case of pulmonary embolism. And what do we see in the clot which has occluded the pulmonary artery? You see here, what are these? Remember, we saw these lines in the clot when we did the circulatory system cases. What are these lines and what is their significance when we see them in autopsy material? What do you think this is? Remember? Yes. No, it's a thrombus. It's not fat embolism. That would show in histology. If we had marrow, bone marrow tissue, that would be fat embolism after breaking of bones, long bones. It's a thrombus, but when we see a thrombus in a vessel, we must discriminate if the thrombus has formed post-mortem or if it has been formed when the patient was alive, and it is the cause of death in this case, because this is massive pulmonary embolism. So we see these lines. Remember, we had a case in the circulatory system known as Zahn lines. Some lines are from red blood cells. Other such lines are from fibrin platelets, and this tells us that there was a flow of the blood over the wall where the thrombus was formed. That means that this is the cause of death, and it's not a post-mortem thrombus. Let's have a look at these patients. Yes?
Can you repeat what you said? Why do we know it's post-mortem and not...
When the thrombus was formed when the patient was alive, we see these lines, the Zahn lines, highlighted by the sign there. You see?
Okay.
So this is a clue to make the correct diagnosis. Now, let's have a look at the blood gas values. pH is 7.5. What is this? 7.5. What do you think is this? If you find it. This is alkalosis. Correct. Then, what do we see next to define if the alkalosis is respiratory or metabolic? What do we see? The partial pressure of dioxide, carbon dioxide. This is 30. That means it's low. All right? What do we see next? We see if this respiratory alkalosis is compensated. Who will tell us that? What will tell us that? If there is compensation of the respiratory alkalosis. Yes? The bicarbonate. So, you see, it's normal. What does this mean? It's non-compensated, that's right. You see that pH is high, yes. This would show hyperventilation. That's why the partial pressure of the arterial blood, the partial pressure of carbon dioxide is low. The pH is high, yes. And look here, the partial pressure of oxygen remains low even after the patient is given 100% oxygen. And pay attention to this. The very characteristic finding of embolism is the detection of D-dimer, because this is a sign that fibrinolysis has started after the formation of a thrombus. So in cases that you have patients with dyspnea, do not forget to order the D-dimer and detect the D-dimer values. Yes? The Zand lines, yes. Perhaps it's more evident in the microscope, however, this line here. You see here, this line? These are alternating lines between red blood cells and fibrin. These are Zand lines. Yes, so we had the elevated D-dimer, yes, and the blood values. Yes. Now, let's have a look here. This is a 34-year-old man who has a motor vehicle accident resulting in blunt trauma injury to the chest, abdomen, and extremities. So, multiple traumas. He is hypotensive. What's this sign when we have such a patient and we find that his blood pressure is low? What is this sign? How is it evaluated clinically? This is a sign of, when we have low hypertension, of shock. All right? A sign of shock. And the hematocrit is low. How can you justify this? Why is the hematocrit low? It's easy. Loss of blood, of course. And over the next week, we see that the oxygen saturation deteriorates. He requires intubation and mechanical ventilation to support his breathing, and increasing positive and expiratory pressures and fraction of inspired oxygen. That means this is what the content of oxygen is in the gases with the air in the lung. When you give oxygen, of course the patient will need oxygen so that the blood is oxygenized. However, you should take into account that when we have increased portions of oxygen exogenously given to the patient, this may be toxic to the lung parenchyma. So, and this is the chest scan. What do you see here? Throughout, I'd say throughout the lung. Look at all these lines here. What can this be? This is diffuse alveolar damage. That means that the lining of the alveoli has been destroyed. This is the acute respiratory distress syndrome, in this case of adults. So if the lining is destroyed, the changing of the gases can no longer be possible. So it's a very serious disease, and here it accompanies an acute lung injury after the accident. And this is called shock lung, followed by extensive thrombosis from the tissue factors released. And we'll have a look at the histology. And these are diffuse. See how they are dispersed throughout the lung parenchyma. Diffuse ground glass infiltrates. So we have an injury to alveolar capillary endothelium, and both epithelial lining epithelia are destroyed, both type 1 and type 2. What are type 1 pneumonocytes responsible for? What is their function? Type 1 pneumonocytes, the exchange of gas. Type 2? The factor surfactant secretion, yes, and they also are involved in the immune response. They have an immunomodulatory function, type 2 pneumonocytes. So, This destruction leads to exudation of plasma proteins, and fluid fills the alveoli, which coalesce. And what do we see on histology? Instead of the normal lining of alveoli, we see these hyaline membranes. The syndrome has a diverse pathogenesis. It could be encountered in newborn, but before they are correct, premature newborn, where there is not enough time that surfactant is produced. So we have the same histology here as here. That would be of the newborn, the diffuse alveolar damage of the newborn. Here is of the adults. So we have a 20-year-old woman with a septic shock, and she has developed pulmonary hypertension while being on a shock. That means being on a shock, she was hypotensive. This patient developed pulmonary hypertension due to this diffuse damage, which probably affected the microvasculature of the lung. That's why she showed pulmonary hypertension. And what caused the hypertension and the role that sepsis? So this is hypoxia, and we have retention of carbon dioxide, pulmonary vasoconstriction, and this pulmonary vasoconstriction is related to the development of pulmonary hypertension. If we have constriction of the vessels, hypertension develops. Hypoperfusion, we saw the hyaline membranes, and you see the walls are somehow thickened. However, there are no pneumonocytes lining the destroyed alveoli. And of course, this required increased positive pressures and high levels of inspired oxygen, which proved to be toxic itself. So the problem persisted, and we had a vicious cycle of ongoing injury and worsening ventilation and perfusion. And of course, this can prove fatal to the patient. So one factor related to diffuse alveolar damage is infection, but there are other factors as well. And a key factor is nuclear factor Kb, which results in this increase of cytokine, inducing inflammation. Yes, please?
So the damage here is caused by the oxygen?
Yes, in the present case, it made it worse. But there was no other way for the blood to be properly oxygenized. Now, here, we have an 83-year-old man with a 3-day history of productive cough and fever. And we hear crackles over his right upper lobe, and his blood cells are increased, white blood cells. Here is the chest radiograph. What can this be here? Why does this area appear such bright? Yes?
Pneumonia.
This is pneumonia. This is consolidation. That means something has filled the alveoli, so they have no longer air in the alveoli, but instead of air, we see the inflammatory exudate. So this is pneumonia. When we use the term pneumonia, in most cases, this is the case that we are talking about. If we have the term interstitial pneumonia, that means that something happens in the connective tissue, and there is no exudate, no inflammatory exudate as here. And also, there is another term known as pneumonitis, where we have inflammatory cells not within the alveoli, but in the septa among alveoli. So these are the three terms having to do with the presence of inflammatory cells in the lung parenchyma. But in this case, we have pneumonia, and if it occupies, if the inflammatory infiltrate occupies a whole lobe, we talk of lobar pneumonia. If there are some dispersed foci of inflammation tissue affecting bronchi and the adjacent alveoli, we talk of bronchopneumonia. So let's see the organisms. Now, what organisms are most likely in the setting of such a community-acquired infection? Why does it use this term community-acquired so as to discriminate from a pneumonia that the patient gets in the hospital? Because in this case, there are other infectious agents probably involved as causes of inflammation, of pneumonia, and the nature of the inflammatory process. So this is consolidation of the right upper lobe. This is lobar pneumonia because a whole lobe has been affected by the inflammatory exudate within the alveoli. And the most common causal organism is Streptococcus, but also we have other microorganisms such as Haemophilus. You see here all the other infectious agents. And these consolidations, when we look at histology, has acute inflammatory cells. It's most logical because we have bacteria. So neutrophils logically predominate as the first cells in response to a bacterial infection, and they enter the air spaces of alveoli, filling them. And of course, we have transudated fluid and proteins. And this patient, when he has a sputum, since there is pus in the alveoli, the sputum will appear somehow yellow to green, and this will be a sign of pneumonia, lobar pneumonia. And if the causal agent is not eliminated, fibrosis may develop in this area, so perhaps we'll have a complication of destruction and deformation of alveoli due to scar tissue formation. And in case the exudate is destroys all the septa of the alveoli and all the exudate forms a cavity, makes a cavity in an area where no such cavity pre-existed, but the lesion makes the cavity, and we have pus in the cavity, and the surrounding zone of viable inflammatory cells. Viable means that we see nuclei in the neutrophils, whereas in the necrotic area within the cavity, we do not see nuclei because this is pus. We see nuclear dust there. So we have a zone in the center of the cavity where we have pus. Then we have a zone of viable inflammatory cells, and then we have connective tissue development, making all this like a cyst filled with pus. And what complication is this? If we have the formation of a cyst filled with pus and surrounded by fibrous tissue, how is this called? This is an abscess. So probably bacterial pneumonias may be complicated by abscess formation. But we'll continue on Monday and study all cases, other cases of pneumonia. So have a nice weekend.